Hello. So in this video we're gonna talk about tuberculosis. So how it is spread, how it is caused. So tuberculosis is caused by Mycobacterium tuberculosis, which is a bacillus, meaning it is a rod-shaped bacteria. And how it is spread? It is spread through coughing of infected person. When an infected person coughs, 3 to 4 bacillus gets aerosolized and into the air, meaning dispersed into the air. Person who inhales the aerosolized air gets Mycobacterium tuberculosis 3 to 4 bacillus into its lungs, and it goes straight into the alveolus. And so now we're going to talk about pathophysiology. So how the development of disease occurs. When the infected person inhales, it goes into the alveolus. After it goes into alveolus, the first line of defense, which are macrophages. What macrophages does is it should kill or inhibit the bacteria. Mycobacterium tuberculosis, it should inhibit it. But if it is not able to inhibit, then what will happen? It will grow rapidly. It will grow rapidly. When it grows rapidly, then it can go into the systemic circulation. When it goes into the systemic circulation, it can go and infect any part of the body. But most of the time, it goes and stay in the posterior apical of the lungs. Why it goes into the posterior apical of the lungs? Because it has two main reasons. First, it is rich in oxygen, and the Mycobacterium tuberculosis needs high amount of oxygen. It is an aerobic bacteria, rich in oxygen, rich in O2. And second reason is that it has a very low immune system there, means immune cells are very low there. So that's why it goes and resides there. After when it goes and resides there, then what will happen? After 2 weeks of infection, it will go and multiply. After 2 weeks of infection, the T lymphocytes will get activated. T lymphocytes will get activated, and then it gonna go and kill the Mycobacterium tuberculosis. So sorry, but not 2 but 3. After 3 weeks of infection, the T lymphocytes will get activated and go and kill tuberculosis. How it will kill? It will secrete INF gamma, which is interferon gamma, and other cytokines, and it will also tell the macrophages to become bactericidal, meaning to go and kill yourself, and yourself also the bacteria, meaning apoptosis. Apoptosis is programmed cell death. It is the T lymphocytes is programming the macrophages to go and kill Mycobacterium tuberculosis. Then we will move to, after that, when it will become this is called as CMI, which is cell mediated immunity. And after that, the activation and rapid activation and proliferation of the T lymphocyte is called as DTH. DTH means delayed type hypersensitivity. And it will go, the macrophages will become granuloma, meaning it will go and trap the Mycobacterium tuberculosis inside it in the caseous region. Caseous region means cheese like. what the Mycobacterium tuberculosis will do, it will cause the it will infect the lungs and reside in it, and it will eventually kill the lungs, meaning it will become cheese like in appearance. The lungs will become cheese like in appearance, gaseous cavity or area region. Now this much is done. After that, it should come in check, meaning it should stop, meaning the infection should stop. Now we will discuss about reactivation of infection. So about 10% of the patient who all got infected will develop the second infection in their lifetime, and 50% of the patient develops this tuberculosis within 2 years of first infection. Then we will talk about the clinical presentation. Now we will come to the clinical presentation, which is signs and symptoms. So what will be the symptoms of tuberculosis? There will be cough, fatigue, fever, night sweat, and also lastly weight loss. This weight loss is important factor. Then we will come to the diagnosis. How we will diagnose this disease? First is Mantoux test. Mantoux test is the test in which tuberculin will be injected subcutaneously into the hand, arms. Then the area of induration will be seen. Induration means bump. Bump will be seen. If it is around 5 mm, and if the patient is HIV positive, then most probably we can confirm it like that the patient has tuberculosis. Otherwise there is 10 mm and 15. If it is 15, then we can definitely confirm that patient is having tuberculosis. Then we will go with the physical examination. In the physical examination, the physician or the doctor will do the percussions to diagnose. This will not be done alone, but with the tandem of other investigations. In laboratory test, there will be high WBC, increased WBC, increased platelet count, and also there will be mild to moderate anemia. After that, in chest X-ray, there will be infiltrates, patchy infiltrates, and sometimes there will be cavity. When the infection is very severe, then there will show a cavity in the chest X-ray. When then the acid-fast staining. In acid-fast staining, what will happen in acid-fast staining? That continuous 3 days of blood sputum will be taken in the morning, which will have the maximum number of bacterial load, and it will be confirmed with 3 sputum continuously, and this is one of the most accurate diagnosis. Now we will move to the management. So in management, first will come non-pharmacological therapy. So what will happen in non-pharmacological therapy is firstly the contact tracing, meaning we have to go and ask the patient how you got the TB, from where, and then we have to trace the other person, contact tracing. And the second one is when the patient is presented into the hospital, the patient have to be put it in a negative pressure room. What is negative pressure room? That the air will come from outside to inside in the ward, but not from the inside of the ward to the outside. The reason is simple. we don't want the infection to spread from the one room to the other room and into the hospital. We don't want hospital acquired mycobacterium tuberculosis. We don't want hospital acquired tuberculosis. So let the air come from outside into the inside of the room. Then we'll go to the pharmacological therapy. Okay, so now we'll move to the pharmacological therapy. In pharmacological therapy, first we have to treat the latent infection. Latent infection. Latent infection means that the patient just got infected and he or she is not showing any signs or symptoms. So how we will treat? It is very simple. So we have to take isoniazid. The recommended guideline is isoniazid for 9 months alone. Isoniazid alone for 9 months, and the dose should be 5 to 10 mg per kg body weight per day, which should be around 300 mg per day. And then it should be isoniazid should be taken on empty stomach, on empty stomach, and the antacid should be avoided till 2 hours. After 2 hours, antacid can be taken, or it should be avoided for 2 hours. Then if the patient is not able to tolerate isoniazid because of its side effect, so rifampicin can be given. Rifampicin can be given for 4 months. For 4 months. What will be its dose? 600 mg. Or in place of rifampicin, rifabutin can also be given. Rifabutin can be given for 4 months, same, and the dose of rifabutin will be 300 mg. Right, now we will go with the treating the active disease. Treating active disease. How will treat the active disease? So the guideline recommends for 6 months of the therapy. For the first 2 months, all the HRZE will be given. HRZE, which is isoniazid, rifampicin, pyrazinamide, and ethambutol. Next 4 months, HR can only be given, which is isoniazid and rifampicin. Next 4 months, if isoniazid, rifampicin and pyrazinamide susceptibility is seen, then ethambutol can be stopped at any time. Now we will come to the side effects of these drugs. These both drugs, isoniazid, rifampicin, pyrazinamide and ethambutol. We are discussing about the major side effects. For isoniazid, peripheral neuropathy is the most common major side effect, and also seizure and coma, which is in high dose. It affects in high doses of isoniazid. And in rifampicin, arthralgia, which is muscle pain, it is very common, and hemolytic anemia or acute renal failure, if the patient shows these two symptoms or either one of the symptom, then the rifampicin should be stopped. It should be stopped. Then comes the pyrazinamide. What will happen in pyrazinamide toxicity? There will be increased serum uric acid levels, and which can precipitate gout, and also arthralgia is very common. In ethambutol, retrobulbar neuritis, which is the inflammation of the optic nerve, which is the behind the eyes. And that's it, guys. That's it for the tuberculosis. We'll see in the next video.
Thanks for watching PharmD Explains. Don't forget to like this video and subscribe for more pharmacy facts.